Next up, we're going to hear from Dr. Ewa Czyz. Dr. Czyz is a assistant professor in the Department of Psychiatry at the University of Michigan. Her research interests focus on questions of how we can best identify and intervene with youth that are at risk for suicidal behavior. She's especially interested in intervention development for youth at elevated suicide risk, with a particular emphasis on identifying adaptive interventions that can inform the provision of tailored support, as well as the integration of technology, things such as text messages, to augment suicide-specific interventions. I would remind you again to please type your questions in the Q&A portion of the box, and that can be done throughout the talk. And then we will ask her during the live session at the end of the session. Please join me in welcoming Dr. Czyz for her talk.
Hello, thank you so much for the opportunity to be part of this event. In my presentation, I'll describe a recent study focusing on developing a brief intervention for youth at elevated suicide risk, and I'll particularly highlight how technology can be used to facilitate brief interventions for this population. And so I first wanted to acknowledge the many collaborators who are listed here who are involved in this work, participating youth and families, funding from the National Institute of Mental Health, as well as the Nyman Family Unit at the University of Michigan, where we recruited a number of our participants. Many of you in the audience may already be familiar with the sobering statistics, letting us know that youth suicide is the leading cause of death among adolescents in the United States and has been rising over the last decade. We're also seeing growing rates of non-lethal suicide attempts, with some of the more recent national data from 2019, for example, showing that in the year prior to being surveyed, approximately 9% of high school students try to take their own life. There's also a growing number of young people who are seeking acute services, such as emergency department visits and psychiatric hospitalizations related to suicide ideation and attempts. And the research that I'll present today focuses on psychiatric hospitalized youth, many of whom are especially at high risk for suicide-related events such as hospitalizations and suicide attempts just in the weeks after discharge. And so we know that there's a critical need for interventions after hospitalization, particular interventions that can be tailored to more flexibly meet individual treatment needs of adolescents following discharge, as well as interventions that can be practically implemented to increase reach as well as scalability. So with that in mind, I'll describe our recently completed pilot SMART, which stands for Sequential Multiple Assignment Randomized Trial of a multi-component intervention with hospitalized adolescents. We conducted this pilot to obtain feasibility and acceptability data, as well as to learn about the preliminary impact of intervention components, which I'll describe in a bit, and their sequence on key mechanisms of action, as well as our distal outcomes of suicide ideation and suicide attempts, with the ultimate goal of trying to inform an adaptive intervention for hospitalized adolescents, where an adaptive intervention in this case means it's a type of intervention where interventions or individual components are delivered in a more tailored way. In this pilot, we involved adolescents between the ages of 13 and 17 who initially received an in-person safety planning intervention at the time of hospitalization, which included an individual and a family session. And for those of you who may not be familiar with safety planning, it's a brief suicide-specific intervention that at its core really focuses on encouraging healthy coping to avert a crisis and to be used in moments of crisis to reduce the person transitioning from thinking to suicide to acting on the suicidal thought. However, we know from prior work as well as anecdotally from clinical work that some teens do not reliably use their safety plan after discharge and may rely on less adaptive coping or suicidal behavior to manage the stress. And so we wanted to augment the safety planning intervention with additional post-discharge context delivered by text messages or by telephone boosters to increase important mechanisms such as coping behavior, safety plan use, and self-efficacy to refrain from suicidal action. And one of the important questions that a smart design like this can address is how to optimize the delivery of these intervention components and how they should be best sequenced to improve outcomes after discharge. And so when looking at the design, what happened is that our participants were initially randomized to the safety planning intervention that was delivered prior to discharge, with or without supportive text messages that were provided for 4 weeks after discharge. And I'll come back to the text messaging piece and what that involved. And then 2 weeks after discharge, participants were again re-randomized to receive or to not receive a booster call that was delivered with parents and with adolescents. And for all youth in the study, we also included daily monitoring of suicidal ideation, as well as our mechanisms of change to see how teens are responding to these intervention components. And because we were assessing suicidal ideation every day, there was an on-call study clinician who monitored daily risk. And if there was a concern about risk, the clinician would reach out to the family and check in and do an assessment, like a brief assessment. So the monitoring piece is included as part of the design as a result. And in terms of the texting component itself, which is shown here on the right, we sent 2 supportive texts per day for 4 weeks. The first one came in the morning and was pushed to the participant. And the second in the afternoon was optional. So the teen could request or pull the second message if they chose to. And the texting, the text messages themselves, some of them were standard, so everyone received the same message. Some messages were more interactive, and some were personalized based on the safety planning intervention that was delivered prior to discharge. And one thing that I really want to highlight is that the supportive text messages were developed prior to the pilot with significant input from adolescents. So I'll just very briefly highlight what that involved. We recruited initially 25 adolescents to review each and every message that we were developing to give us guidance on both the content and the language that we were using, and really try to tailor the messages such that the teens would find those messages acceptable. And then once we develop our kind of bank of messages, if you will, we involved 15 adolescents who experienced the intervention as a whole for the entire month after discharge. So they received 2 messages over the course of the day. And then at the end of the day, they gave us feedback about whatever messages were sent that day, kind of in a more real-time fashion, in terms of seeing how they are perceiving and responding to that message of the day. At the end of the study, we interviewed everyone and to get a sense of how they perceived their experience in terms of receiving that intervention. And just for the sake of time, I will very briefly highlight that what we learned is that overall the messages were perceived as being acceptable and in a positive way. The teens were very much aware that this is not an intervention that's being delivered by a live person. They didn't seem like they were expecting there's someone on the other line, on the other side, texting them back. And so they did recognize the limitation that this is not the same as talking to a real person, or not the same as the actual intervention. So back to the Pilot Smart, and what do we actually learn in terms of the preliminary impact of the intervention of the texting support on some of the outcomes we were interested in. So here on the left, this is the comparison of teens who received text-based support and who did not receive text-based support. What we see is that teens who were initially randomized to receive texting with safety planning had higher likelihood of using their safety plan daily. So these mechanisms were assessed each day for 4 weeks. And so they reported higher safety plan use over that 4-week period, more coping by support seeking, and a higher level of self-efficacy to resist suicidal urges. In addition, teens in this condition also reported lower intensity of suicidal thoughts over the 4-week period. Then on the right-hand side, what we see is that teens who received the booster call, irrespective of receiving or not receiving the text messages initially, also had promising results in terms of more coping behavior by support seeking and greater safety plan use. And finally, the results also suggested that supportive text had a promising impact on reducing post-discharge suicidal behavior, which included suicide attempts, interrupted attempts, and aborted attempts, which we assessed over a 3-month follow-up period. So teens who received the sequence of safety planning with texting and who in addition had the booster call appeared to be especially protected. So teens in this condition did not report any suicidal behavior. However, because this is a pilot study and we were not really powered to examine this in a definite fashion, it's important to remember that these results are very, very preliminary. And in our future work, we hope to conduct a full-scale SMART to more definitely address the question of how much supportive text messages are beneficial after discharge and how and for whom they should be combined with other supportive follow-up strategies in a more adaptive way to improve post-discharge outcomes. So just to summarize very briefly, we need effective but also scalable and practical continuity of care strategies to improve post-discharge outcomes in youth at risk for suicide. Our work, this pilot work suggests that augmenting best practice safety planning with text-based follow-up may be promising, and that in some cases supplementing those contexts with a booster call may be especially protective for youth after discharge. Future and fully powered initiatives will focus on identifying how to optimally combine in-person safety planning and follow-up intervention components that integrate technology, including text messages, in order to provide more adaptive or tailored post-discharge support for the youth at elevated suicide risk. Here's my email if you'd like to reach out to me, and I'm also happy to take any questions you might have.
Great. Thank you, Dr. Czyz, for that great presentation and all of your work in the area of suicide prevention. This starts the live Q&A portion for your talk, and I'll just remind all of our viewers watching to please enter any questions that you have in the chat so that we can ask them here in real time. One of the first questions that we have is, it's so important for the type of interventions that you described to really involve the population of interest in developing the intervention. And it was really great to see how you did that with your messages and the development of your messages. I'm curious what you learned from involving youth in the process of the message development.
Thank you for having me. Yes, I think that it's really paramount to involve the actual stakeholders and the consumers of the intervention. So we, as I was just sharing in the talk, we did this over a 2-phase period. I think what was really interesting is sort of learning how teens perceive these messages as they were coming in each day. We certainly had different feedback when doing this kind of a day-to-day basis versus doing it at the very end of the study. So I would just encourage people to think about, kind of the design even of this formative work. It wasn't really designed to look at any efficacy or effectiveness, was really designed to see what do you think about it. But we learned very different things by having people both give us feedback on each message, then kind of experience the intervention, and then sort of at the end, what was their overall perception. And so I think that it really helped us fine-tune the messages that we were thinking about. It helped us drop some of the content that we thought would be helpful, but really wasn't from the perception of the teens. And I think something that was really surprising is that we learned that some of the teens felt that the messages, that they really appreciate that someone was checking in with them, even though it was a one-way interaction really, but they felt like someone cared. So that's something that we weren't really aiming to target with this intervention. That wasn't really a mechanism for us, but just the idea that someone is rooting for you to do well. And that was something that came through from the qualitative feedback we received.
That's interesting. I feel like one of the things that we hear a lot with, and today's all about technology and injury prevention. One of the things we hear a lot about with text messaging interventions or electronic or automated interventions is just that sometimes they can come across as formulaic and not as personalized. And you dealt with that a little bit with some of the personalized messaging, but also other thoughts on how to overcome that, or does the involvement of youth in the process early on to help develop those messages help overcome some of that formulaic sort of component?
Yeah. So, what was interesting, which I don't think I was very clear about, is that the intervention did involve an in-person component initially. So the teen met with a study counselor And the intervention was very focusing on safety planning. It's a very brief intervention, but it's very heavy in motivational interviewing as an approach. And so I just wonder if the perception of the texting sort of was really influenced by that initial session with a person, and whether the teen just felt more care about because it felt like it was coming from someone versus sort of kind of more just kind of neutral place. The messages, we did try to tailor some of them to reference that meeting. So my sense is that probably had something to do with it.
It helped to personalize it to them and their experience prior with the therapist.
Right, yeah. Right. I think that's sort of what we're learning more about when we think about technology, that a technology that has a bit of sort of this like human touch or kind of the warm handoff. My understanding is that those interventions tend to fare a little bit better than kind of fully automated, no human contact ones.
Right. Yeah, that's a great point. And I'm interested. One of our audience members is interested in sort of why only youth and not involve, the broader family or parents in the intervention with text messaging.
So for this particular project, we did focus on the youth in terms of the texting component itself. The in-person intervention I mentioned, the safety planning one that happened prior to discharge, did involve the parents. So there was a meeting with the youth and then a meeting with the parent. The texting did focus just on the teen. And then there was the booster call that I mentioned in the presentation. That one involved the youth and then separately with the parent. We made that decision at the time because of the preliminary nature of the study and just trying to learn, what do you think about the texting? I do think that in future work, it will be important to involve the parent as well. Right now, we are focusing on a new initiative separate from this work, where we are actually developing a text-based supportive intervention for parents, for caregivers of youth who were seen in an emergency department setting for suicide-related concerns, where the idea will be to follow up with the parents. And that's really our target population, even though we are, of course, interested in preventing youth-related outcomes ultimately. But the idea with the text-based support for parents is it's a little bit different. It's a little bit personal. So we just started collecting that data. This week, actually, we just launched the study. So I'll be curious to see what we learn.
Great. There's another question in the chat that actually sort of piggybacks on the earlier one I asked about sometimes text messages feeling formulaic, especially with youth and adolescent youth populations. A lot of times their communication is more in a text or electronic format. And I'm curious if you think that may have played a role in them being more comfortable with that as the intervention post the brief intervention that you described.
It's hard to answer that question with certainty, but we were very careful about how the messages were phrased. So we did actually rely a little bit on MI to phrase a message so that it's really honoring the teen's autonomy, and it's not sort of feeding them information or pushing something onto them. It's a little, the language we try to make very collaborative and really, it being up to them whether or not they consider, if it was a tip or a suggestion or a reminder of something. So I wonder too if it was sort of the technology itself and teens being really used to it in combination with whatever that initial meeting kind of transferred over, if you will, to the interaction. And also, I think just the way we try to deliver the content for it to feel caring, but also feel like it's supporting their autonomy and their choice.
We heard a little bit earlier from Dr. Resnikow about using, screenomes or recent web searches to detect depression symptoms. And I'm curious if you gave any thought about how that type of technology might apply in your own work around detecting increased risk of suicidality or using that type of mechanism, or if that's something that you guys have looked at in your team.
Yeah, so my work primarily focuses on kind of the high acuity clinical populations. But I do think that kind of the promise of technology, both like technology, the way we think about sort of the devices and sensors, But also, I think technology defined broader to include things like machine learning, I think it does have promise in our field. Some of the work we're doing right now, we're actually trying to leverage machine learning and sensors and kind of more frequent assessment to try to see if we can pinpoint when someone will experience a crisis. And so the idea will be long-term to kind of marry the two, marry the intervention piece, but also the detection of risk piece, and try to tailor more, not just as we did in this work, where we're sort of pushing the messages each day, but can we tailor when they're also pushed to more closely kind of meet whatever the individual is needing at that moment.
It's kind of a just-in-time component, yeah.
A bit of a just-in-time component. Mm-hmm.
So just curious, as sort of a final wrap-up question here. So you talked a little bit about next steps, but I'm curious how you think your future research is going to build on the pilot and what the next stages of this are.
Yeah, so I'm happy to share that we actually just recently were funded for a large-scale SMART that builds on this work. And we are hoping to try to replicate or learn if we can replicate the main finding where we found that texting was useful in terms of preventing some of the outcomes we're interested in preventing. We'll be adding on some additional pieces to that, where one of the main pieces we'll be adding is a portal, like a web-based intervention that will be provided to parents and to youth who are flagging as not doing well. So we're trying to sort of balance providing interventions, but to people who may be kind of showing early signs of risk versus to everyone, kind of being mindful of the scalability of an approach like that and just the burden on healthcare systems. And so we're trying to provide kind of these sort of low touch texting to most people and then see who else needs sort of more kind of personal contact with a counselor.
Yeah, great. Right dose, right modality, all that great stuff. So it's really great to hear about your work, and I appreciate you coming to talk to us, Dr. Czyz. And I think that takes us into our break. So next we will be taking a short 10-minute break, and we will resume at 2:25 with the second portion of our afternoon.